Good evening, everyone. It's Angela Newbound. I'm presenting tonight's webinar. So I'm so pleased that so many of you joined and that you have really joined nice and early, so we're all set to go. We've got a fair bit to cover. For those of you who have not heard any of the webinars from the Immunisation Coalition before, I do present a number of them. My job in real life is as the Immunisation Hub Coordinator for the South Australia PHN, and I'm based in the Adelaide PHN. So I thank the Immunisation Coalition for inviting me to present the webinar tonight. We do, originally this webinar was going to be about pneumococcal disease, but there were so many requests coming forward for some information around the changes for the new NIP schedule as of the 1st of July. So we've shortened the number of slides for adult pneumococcal disease, and we've got a greater part of the evening is going to be talking about the schedule. So in regards to the questions coming into the question box, I will sort of try and, navigate those, as we go. And there was already a question there which I've just responded to, basically talking about the children that have not yet had pneumococcal, and they may or may not be eligible, depending on what their meningococcal vaccine status is. So we'll start with pneumococcal disease, and we'll work our way through, and we're sure to get to that new schedule and hopefully get some questions answered. I think most of you are probably very, very familiar with pneumococcal disease. You may or may not have seen pneumococcal disease in any patient, but it's quite a nasty disease, and it is responsible for more deaths worldwide than any other single pathogen, which is really quite amazing when you think of it, because it's not the type of disease that tends to hit the front page of newspapers, etc., but it is a really serious disease. It's really got a very complex polysaccharide capsule around the outside of the bacteria, and that polysaccharide capsule is really important when they are making vaccines such as your Pneumovax 23 and your Prevnar 13, where they're actually taking a piece of that polysaccharide capsule away in order to create the vaccine. Depending on the composition of that polysaccharide capsule will depend on the serotype of the pneumococcal disease, and we know that there's probably around about 90 serotypes. Most of us will carry this particular pathogen in just the upper respiratory tract. We are the reservoirs for it. In the majority of cases, it just doesn't make us sick, but for some people, it does make them sick. If it's diagnosed early enough and we can put people on the right antibiotic at the right time, they really become non-infectious within around about 24 to 48 hours. So it can present in a number of ways, and this is why you may or may not have seen a patient with pneumococcal disease, because it just doesn't present as a pneumonia all the time. It certainly presents as a pneumonia in a lot of cases, but certainly when we look at pneumococcal disease, which can be either non-invasive or invasive, and non-invasive form is what we most commonly see as an otitis media, really, in children. Around about 30 to 50% of middle ear aspirates from children with acute otitis media comes back positive for pneumococcal. So invasive pneumococcal disease, however, is really when that bacteria is detected in normally sterile sites, such as your spinal fluid or bloodstream. So It can be treated with antibiotics. However, there is antibiotic resistance that is occurring. So therefore, really we need to be talking to our patients about pneumococcal vaccines. It is the best way to afford them a level of protection from this particular disease. So invasive pneumococcal disease, what is it? Like I said, it was really, you know, when we start seeing this particular bacteria in normally sterile sites. It does cause disease of the lower respiratory tract, and whilst pneumococcal pneumonia in itself is not considered to be invasive disease, we do know that it can be life-threatening. Pneumonia can also serve as a focus for bloodstream invasion, and therefore it can lead on to invasive pneumococcal disease, and it's often referred to as IPD. Pneumonia with bacteremia is the most common manifestation of IPD in adults. And it accounts for, or bacteremia more so than pneumococcal pneumonia, it accounts for about 70% of invasive disease in children, with pneumonia as the second highest reason for invasive disease in children. So there are, you know, when you look at the surveillance of pneumococcal disease, we do see that there are peaks in the elderly, and there are certain peaks in our very, very young children. So you can see mostly cases are in the over 65 age group, but there are significant cases of invasive pneumococcal disease in children under the age of 5. So this will play a really major role when we start talking about why there were changes to the schedule back on the 1st of July. Just out of interest, if we're looking at notifications here in Australia year to date, so this year to date being the 16th of July was the report that I checked. So far, there have been 821 reports of invasive pneumococcal disease in Australia. 144 of those cases are in children under the age of 5, and 312 cases in people over the age of 65 years. So you can see by this particular graph that pneumococcal disease has remained relatively persistent despite immunisation, and there's probably, you know, a reason that we can actually explain that in regard to the fact that not all of those 90 serotypes, for starters, are actually vaccine preventable. The other reason that we're still getting invasive pneumococcal disease is because not everybody's getting the vaccines that they need. And unfortunately, the vaccine effectiveness of something like Pneumovax 23, whilst it does help control perhaps the complications and the seriousness of disease, it may not be overly effective really when we're looking at stopping people from getting pneumococcal disease. So, a little bit of a guess for our first poll. In 2016, in non-Indigenous Australians over 65 years, have a try and guess which types of serotypes were causing the highest amount of invasive pneumococcal disease notifications. And you'll see your poll come up shortly. Nope, no poll coming up. Okay, a few of you are having some guesses there in the chat box. Okay, good job. You did pretty well. You did pretty well. Okay, so just the polls coming here now. Let's have a little look. Okay. So most of you thought that it was number 4, which was the 13-valent serotypes rather than the 7-valent serotypes. However, if we get rid of that, the answer is actually, believe it or not, the answer is actually C. Whoops. And if we have a look at this particular graph here, you will actually see over on that right-hand side for 2017, you will actually see the dark, like the red bars. That red bar means that they were non-vaccine serotypes. So this is why when we're talking about how pneumococcal disease has really remained present, it could be the fact that there's just so many non-vaccine serotypes that are actually circulating. So who is at risk of invasive pneumococcal disease? And we just talked about the fact that it's children under the age of 2 and it's the elderly. But also Aboriginal and Torres Strait Islanders are also at risk, and there are certain medical conditions that put people either at increased risk of invasive pneumococcal disease, which is your category Bs, or the highest increased risk of invasive pneumococcal disease. So it's really important when we are doing our pre-vaccination checklists, when we vaccinate, that we're actually assessing to see whether people do have these serious medical conditions, so we can then consider what pneumococcal vaccine we should be offering them. So if we have a quick look at people with underlying chronic illness, there is really very, very good evidence that people with these certain chronic illnesses have a much, much, much higher risk of invasive pneumococcal disease compared to a healthy adult. So why would you ask that question? So with diabetes, there is the increased risk of those lower respiratory tract infections. We've got to remember what diabetes actually does to our body, and we've got to think about what these pathogens actually do in regards to vessel walls, for example. We know people with diabetes often have peripheral disease. They have, really veins that don't work very well. And these sorts of infections, such as pneumococcal disease, and whether it's influenza or whether it's zoster, they all cause plaque destabilization. So if you've got people with unhealthy vessels, they've got plaque on them, then bits of that plaque can actually fall off because of the way these diseases actually impact on that inflammatory process of vessels. When you've got diabetics that have got really poor glucose control, they end up losing a lot of elasticity of their vessel walls, and that poor glucose control, once again, that glucose control can be impaired by having something like pneumococcal disease as well. And it's very similar to the chronic heart failure patients. You've got people who don't have a good heart. You've now got these people with poor vessels getting diseases like pneumococcal disease, where they're going to get that inflammatory process happening, and therefore they're going to end up, potentially at risk of having strokes or heart attacks. So important that we do follow the vaccination recommendations in the handbook, and that's the online version, so make sure that you're all using that. If you've got hard copies of this handbook, please, please, please just throw them away, because they are just so far out of date, and you could really be following the wrong guidelines. The pneumococcal chapter in the handbook is probably the most difficult chapter that you will ever try and interpret, and it's a very complex disease, and therefore there are complex vaccine recommendations. So we will talk a little bit later in the presentation how we might be able to make that a little bit easier for you. So if we continue on with our people with chronic disease, such as our severe asthma, we also know that they have an increased risk. They've got damage to their lungs already, so therefore they have an increased susceptibility to harbour this infection. If you are a cigarette smoker, or you've got patients that are cigarette smokers, please, please, please work on encouraging them to give up smoking. It is the strongest independent risk factor for invasive pneumococcal disease among healthy adults. So the damage that cigarette smoke does to the mucosal lining and to our airways really puts these people at risk. So please work with them, try and get them to understand that this is a really very serious disease, and they certainly don't want to be getting it. So we've talked about the disease, so we'll have a quick look at the vaccines, and we can see that we've been vaccinating adults for quite a period of time with our 23-valent pneumococcal polysaccharide vaccine, so that's what the PPV actually stands for. And then there was a conjugated vaccine that was introduced for infants. It first started off as a Prevnar 7, and over time it was replaced nationally by a 13-valent, which is what we're currently using. So it's a 13-valent pneumococcal conjugate vaccine, which is a PCV. So quite often when you're talking about these vaccines, people will actually refer to them as a 23-valent PPV or a 13-valent PCV rather than the brand names of the vaccines. Oh, I think we jumped one. Did we jump one? No, that's good. Okay, so if we look at our 23-valent pneumococcal polysaccharide vaccine, obviously 23-valent means that it does contain protection from 23 types or serotypes of the bacteria. Polysaccharide vaccines are not immunogenic in children less than 2 years of age, so therefore they are not recommended to give to children. So this did pose a big problem of how do we protect little children then? If little children under 2 are amongst the highest risk people to get pneumococcal disease, they had to think about how we could protect them if we can't give this particular vaccine to them. And we'll talk about how they did that when we talk about our conjugated vaccine. So this vaccine's been used for quite a long time. There is some thought that there is decline in antibody response. However, there were recommendations made around how many doses we should be actually giving somebody. And so they've now decided that a single dose for a healthy individual over 65 years is sufficient. If someone has chronic medical conditions, they may require 2 doses after the age of 65. The reason I say they may need 2 doses is because it would very much depend on when they started receiving 23-valent vaccines. For example, if you had somebody that was 43 years old, they were diagnosed as a diabetic, and they were given their first 23-valent vaccine at the time of diagnosis, which is according to the recommendations, they would actually have a second dose 5 to 10 years later. So by the time they get to 65 years of age, they would only be requiring a single dose at 65, because the recommendation is that we limit the number of doses of 23-valent down to 3 doses in an adult's lifetime. So it is really important that we do go back and look at our patients' vaccine histories if they have chronic disease, that we do give them that dose at 65, but whether they need another dose 5 years later or not very much depends on whether you've just given dose 1 or dose 2 or even dose 3 to that particular adult. It is thought that there is a bit of an immune hypo-responsiveness or blunting effect when we give repeated doses of this particular vaccine, and therefore there are guidelines around that single dose for a healthy individual and only 3 doses in an adult lifetime if they have got chronic medical conditions. So it's listed on the NIP for people over 65, Aboriginal and Torres Strait Islanders from 50 years of age. However, if you've got Aboriginal and Torres Strait Islanders 15 to 49 years of age and they've got these chronic medical conditions, then definitely they have funded vaccine as well. And also children aged 4 years. On our NIP, you'll notice that we do give a Pneumovax 23 to a child that's got one of these chronic medical conditions. It is PBS listed for other people if they don't technically fit in with the funded program. So our 13-valent pneumococcal conjugate vaccine. So this is still using the polysaccharide coating around the edge of the bacteria, but chemically linking that polysaccharide to a carrier protein. Now the carrier protein is generally going to be, most carrier proteins are either going to be a diphtheria or a tetanus protein. So by chemically linking this carrier protein onto that polysaccharide just means that when we administer this vaccine, our antigen-presenting cells will recognise it as a threat, and when it tries to destroy the antigen, it will spit out proteins onto its surface, and those proteins have come from the carrier protein, not necessarily from the actual polysaccharide component. And this is why pneumococcal disease can evade our immune systems, is because that polysaccharide coating looks very, very similar to some of the polysaccharide coating that we've got on our neural cells. So our antigen-presenting cells don't actually know that they should be fighting it. So we rely on the antigen-presenting cells spitting out those proteins from the carrier protein onto its surface, and therefore calling the T helper cell response into play. Those T helper cells will then release those chemical cytokines and stimulate our B cells, and therefore young children can build very good immune responses with this particular vaccine. We can give this vaccine from 6 weeks of age, but as we're talking about adult pneumococcal disease, we'll talk about adults over 18 years of age that have got a category A highest increased risk of IPD. So just make sure that you are very, very familiar with your category A and category B medical conditions. So adults with category A should be receiving a single dose of 13-valent pneumococcal conjugate vaccine, followed by doses of 23-valent. okay? And they will probably get, or should get, 3 doses of 23-valent in their adult lifetime. So the complexity around what vaccine do you give and when do you give it has tried to be ironed out by this Pneumosmart vaccination tool. I'd really encourage you to jump onto the Immunisation Coalition website and search for the pneumococcal tool or the Pneumosmart tool and have a little bit of a play with it. Go and have a look at some of the patients that you may have on record and put them through the tool and make sure that they've had the appropriate vaccines at the appropriate time. The tool will also say that if there are no written records of this person receiving a pneumococcal vaccine, then as with any other situation like that, we would say that the vaccine has not been administered and we would be starting, right at the start of their vaccine course again. So just, a lot of people don't understand. They don't remember what vaccines that they've had and what they haven't had and which one it was and how long ago, etc. But try and do a little bit of detective work where they may have been seen by someone else at another clinic. Maybe you might need to make a couple of phone calls. So you might need to be a bit of a detective. But at the end of the day, if you cannot find any written records, then please, start them again, and put them through this particular tool. And it will give you all of the guidelines that you need into what vaccine they should be having, when they should be having it, whether it's funded under the NIP, whether it's PBS listed, or whether it's self-funded by the patient. Now, we've just talked about 13-valent pneumococcal vaccine for people with Category A medical conditions who are at the highest increased risk, where they are recommended to have a 13-valent vaccine. That vaccine is not funded and it is not PBS listed. So patients will be required to self-fund that particular vaccine. So that's going to be the end of our pneumococcal talk because we've got so much to talk about with the new schedule. But just bear in mind, pneumococcal disease really is a very, very serious infection. We have got certain people in our community that are at risk of this, either really significant risk with Category A medical conditions or certainly at increased risk with Category B medical conditions. So please make sure that you use your Pneumosmart tool, save it into your favourites so you can go to it at the drop of a hat, basically, and make sure your patients are getting the right vaccine at the right time. Okay, so changes to the schedule on the 1st of July. I'm sure that you've all coped exceptionally well out there because you're just doing such a fantastic job. I really would like to thank Dr. Paul Effler, who's the Medical Director at the Communicable Disease Control Branch in Western Australia, and NCIRS for sharing their slides and sharing a lot of the information that I'm about to present. So, we have quite an array of different schedules around the country. Every state and territory has their own schedule. So please make sure that you are following the schedule in your particular state and territory, wherever you are from. So what are the changes trying to achieve? Obviously, we've been protecting children against meningococcal C disease for quite some time. So definitely expanding that to cover them against other serotypes, being A, W and Y, is going to be much, much better for people like young children who are at increased risk of these particular diseases. Certainly reducing that breakthrough of pneumococcal infections, and we'll talk about that. And then, of course, we've got that big issue of crowding. How many vaccines are really going to be acceptable by providers to administer, but also for parents to consent to? So there was some significant crowding at the scheduling points, so there needed to be a little bit of a shuffle. So if we look at what has changed, it's really 3 scheduling points that have changed, and that's at 6 months, 12 months and 18 months. So previously, children were receiving meningococcal C conjugate vaccine, and most recently it's been given as Meningococcal. So it's been a combination with your Hib, your Haemophilus influenzae type B, and your meningococcal C. So by replacing the meningococcal C component with an ACWY at 12 months meant that they needed to do something with that 4th dose of Hib that Meningococcal contained. So the 12-month schedule was starting to look a little bit crowded, and so it was decided that that 4th dose of Hib really could be given as a monovalent Hib, because we know those vaccines have been around for a long time, and pushed down to the 18-month mark. So with your meningococcal vaccine, it is Pneumococcal that we are using, or Pneumococcal, providing protection against the 4 strains of meningococcal disease. We talked a little bit before about that conjugated protein, and with this particular vaccine, it is conjugated to a tetanus toxoid carrier protein. It does not provide protection against tetanus. It is just purely a tetanus carrier protein that's being used. So, good safety profile. For those of you that have been administering this particular vaccine, it'd be interesting to hear from you whether you're finding any difficulties with it, or whether it's a bit of a painful vaccine. I'm not hearing too much about that, really. I think it's a fairly well-tolerated vaccine. So since the meningococcal C program started in 2003, meningococcal disease has been really, really well controlled. However, there has been this emergence of meningococcal W and meningococcal Y disease across Australia. So for those 2 serotypes, close to half of all the recently reported cases of meningococcal disease have been represented by W and Y. And certainly young children are definitely very susceptible to those particular strains. So if you actually look at IMD, or invasive meningococcal disease notification rates over the years, and looking at the serotypes that are there, you can clearly see how all notifications are looking, and we were travelling beautifully. We had that lovely downward, downhill slope, and now we've started to see a bit of a spike coming back up again. And you can see the little red squares that were meningococcal, that is meningococcal W, how that has risen reasonably significantly. Serogroup C is green, and on the left side of the slide you can see that the numbers were quite significant around 2002, introduction to the MenC program, and we've controlled that disease exceptionally well. Meningococcal B's been bouncing around. There's been a little bit of a decline, but that just stayed around because we've not had a vaccine program for meningococcal B. So this is a very, very similar slide, just using the different colours, and you can see in 2017, for example, the different coloured bars. So you're looking at the purple being meningococcal serogroup W, and our B strains are still travelling around, and that's that dark red colour. You can see the orange bar has started also to widen, and that is our meningococcal meningococcal Y. So you can really see that this increase is really starting to occur. So it was very much a turning point for the government to consider ACWY vaccines for the younger age group. A lot of states and territories have implemented these programs for their adolescent age groups as well, which are another high-risk age group. So if we're looking at notifications by serotype and by age group, you can see that those children less than 12 months or less than 2 years of age have significant disease. You can see there's another little blip around about that teenager age group, and so they are definitely the targeted age groups for these particular vaccine programs. South Australia will be commencing a meningococcal B program on the 1st of October. There will be an adolescent program starting in the school program at the beginning of next year. So the program commencing on the 1st of October is going to be really for young children. So in South Australia, we have a lot more meningococcal B disease than we have of any of the other serotypes. And out of the notifications that we have had so far this year, which has been around about 17 notifications, all bar 3 have been meningococcal B. So if we're looking at meningococcal ACWY doses, it really depends on the age of commencement for this particular vaccine course. So, of course, the government has funded it onto the MIP to be given at 12 months of age, which just means that for healthy individuals, healthy children, it's a single dose only. If your children, if you've got children in your practices that have already commenced on this course, etc., it just needs to be 8 weeks between the doses. But there is only that one funded ACWY dose at 12 months of age. And as I answered the question a little bit earlier in the box, if a child has already had their meningococcus at 12 months of age, then they are not eligible to receive a meningococcal ACWY under the funded program. If parents would like that additional protection for the child, it would be on a prescription and they would need to buy it. If you've got children that have not yet had their 12-month immunisations, in other words, they're now, they could be 2 years old, but they've not had their 12-month-old meningococcus when it was due, then we would be trying to catch that child up and we would be offering the funded ACWY. So the considerations around this particular vaccine program is just double checking whether or not the child has received doses previously. Whilst I have just confused you probably by saying that if a child is 2 years of age and has not yet received their meningococcus, we can give them an ACWY. The wording around there is no catch-up program can be a little bit confusing, because if you've got a 2-year-old that has not yet had their 12-month-old, then technically they're on a catch-up program. If you wish to put your overdue children through the immunisation calculator, it will actually advise you to give an ACWY if the child has not received meningococcus. So when they talk about there is no catch-up program, they're really meaning that there is no catch-up program for children who have already received their dose of meningococcus or their dose of meningococcal C vaccine. It is expected that the children that are 10 to 19 years of age under no jab, no pay will continue to receive meningococcal C vaccine. However, like I said, most states and territories now do have a funded ACWI program for their teenagers, and there is some consideration at Commonwealth level to whether that might be something that will happen down the track on the NIP, but that is certainly very, very uncertain at this stage. So here's another poll for you. You've got a child that's presenting to your clinic, they're 13 months of age. They've not yet received their 6-month-old immunisation, so they are on a catch-up. But the parent only wants 2 vaccines given at any one time. And so therefore, since you've actually got to administer Immunination Hexa dose 3, you've now got to issue your Immunination, your MMR and your Prevnar 13, how do you think you might split that? Do you think you will give the MMR and Hexa and then wait 4 weeks and give them their Prevnar and Immunination later? Or give Immunination and Prevnar 13 first, then bring them back about a week later for Immunination Hexa and MMR? Or give MMR and Prevnar first, then bring them back in 3 days for Immunination Hexa and Immunination? Or give you Immunination and your MMR first, and then bring them back in 4 weeks for your Hexa and Prevnar 13. Just give you a little minute to complete that. Okay. All right. So the answer, believe it or not, is number 2. It would be giving Immunination and Prevnar first, and then bringing them back about a week later for the Immunination Hexa and MMR. Now that recommendation is because that both of the vaccines of Immunination Hexa and Immunination contain the tetanus toxoid carrier proteins, and there may be potential for immune interference. So they're either better off all given on the same day, but if you do have to split them at a parent's request and you cannot convince the parent otherwise, then they do suggest that you split those 2 tetanus-containing vaccines just by about a week. So there's some advice in the ATAGI guidelines and the guidelines and the recommendations that came out by the Commonwealth. So just make sure that you've got those handy. So I hope everybody, I'll just check here and just see what you've said about meningococcal. Can you overdose a child with C? Absolutely not. The one good thing about vaccine, well, there's 1,000 good things about vaccines, but one of those 1,000 things is that we cannot overdose people with vaccine. So our immune system sorts out those antigens exceptionally well. So if a parent does actually want ACWI vaccine and the child has already been vaccinated against meningococcal C, it's absolutely fine. They can go ahead and have an ACWI. Yeah, look, Robin, in regards to the registrations for Immunination is it's what is registered and what is acceptable to use are 2 different things, and the NCIRS fact sheet sorts that out quite well. In the absence of other available meningococcal ACWI vaccines, then there has been some overseas use of giving Immunination to children under 12 months of age. So based on that data, if there were no other meningococcal ACWY vaccines available, providers could use Pneumococcal for sure. And Tassie are doing their own program as well down there by the looks. So let's talk about pneumococcal disease. We're going to run out of time otherwise. So if we're looking at what's changed, you can see here our healthy non-Aboriginal babies in certain states and territories. So the Northern Territory, Queensland, South Australia and WA have an Aboriginal children's program. So for those states, healthy non-Aboriginal babies, that's the previous schedule of Prevnar 13 at 2, 4 and 6 months with no booster. At 1st of July, Prevnar 13 at 2, 4 and 12 months. In other words, it's a 2-dose primary course with a booster at 12 months. With children with medical risk factors, or if they are Aboriginal children, then basically their schedule doesn't change. They still get their Prevnar 13 at 2, 4 and 6 months with a booster at 12 months. So if we're looking at this particular table, it just means that that vaccine for our healthy non-Aboriginal children jumps from the 6 months down to the 12-month mark. So those medical risk factors, just make sure that you've got a full understanding of those Category A and Category B medical conditions. And don't forget, the kids with those medical conditions are recommended to be receiving a 23-valent Pneumovax 23 at 4 to 5 years of age. So we talked a little bit, we just mentioned a little bit earlier about breakthrough disease, and so that shifting that Prevnar is hopefully going to curb that breakthrough disease. And you can see here in 2016, or really over 2013, 14, 15 and 16, we've just seen this steady incline of breakthrough disease in children that have been fully vaccinated against Prevnar with Prevnar 13. So they've all been vaccinated at 2, 4, 6 months of age according to the schedule, and you can see the different age groups where there has been breakthrough disease. So most of that breakthrough disease has been in the child's 2nd year of life. So by moving the 13-valent Prevnar 13 from 6 months to 12 months should decrease the rate of that breakthrough disease. There's some really good evidence that this is going to be a very effective program. There is a very small risk or a potential that going down to the 2 doses plus a booster might cause some vaccine failure in those 6 to 12-month-old children. It's not expected that that will last for very long, but the most important thing is that this program will be very, very clearly monitored to ensure that those children don't have that breakthrough disease, and that if they do, that it's going to be very, very well managed and the program re-evaluated if it is causing too much of a problem. So, another question, another poll. Can our 13-valent PCV, so our Prevnar 13, be given at the same time as other childhood vaccines? Oh, look at you. You're all so smart. Fantastic. Well done. Yes, that's correct. Number 2 is the answer. So just really talk to parents about fever. We've got a lot of young parents that don't even know how to take a temperature. So you might need to ask, do you have a thermometer at home? Do you know how to take a temperature? Do you have some Panadol at home to give the child if their temperature starts to rise? So just, just really make sure that they understand what looking for fever actually means and understand how to manage it and when to seek advice. So in regards to the considerations for this particular part of the program, if they've missed doses of their 13-valent, you do really need to go back to the handbook or the immunisation calculator to determine how many doses of catch-up that they would actually get. For children born 1st of July 2017 through to December 2017 without any increased risks, they may end up receiving 4 doses. So these are the kiddies that have had their schedule of 2, 4, 6 months, and they're currently aged between 6 months and 12 months. Now the schedule's changed on them, so when they get to 12 months of age, please, please, please offer them a Prevnar 13. It will be dose 4 for them, but there's very good medical evidence that having a dose at 12 months will reduce the likelihood of breakthrough disease in that child's second year of life. It does not form part of the assessment for childcare rebate and childcare assessment, so parents won't lose that money from Centrelink if they don't accept Prevnar 13 at 12 months as a 4th dose. However, medically, it is really indicated, so please talk to your parents about that. So, before we go on, I'll just answer some questions. If a high-risk adult patient has already had a 23-valent pneumococcal vaccine, will giving a 13-valent, if they've got a category A medical condition, that would certainly be the advice, is that they do have a 13-valent following on from their 23-valent, okay? If a child has 1 dose of ACY 11 months, the AIR, I have been told, is going to accept the ACWY dose as long as the child has attained 11 months of age. But we do really ask that wherever possible, keep the child on the schedule and please get them to attain 12 months of age before you give them the vaccines. It's just the easiest thing, and then we just know parents aren't going to be penalised because of it. All right. So there are resources available to you, so please make sure that you've got these. There's some good fact sheets on the NCIRS website, National Centre for Immunisation Research and Surveillance. So then if we look at HIB, so what has changed with HIB? So this is what our old schedule looked like. So at 12 months, the MenC has changed to an ACWY, which means we've separated out the HIB. Prevnar 13 has moved across now to the 12-month scheduling point, and that HIB dose has now moved across to the 18-month mark. So this is now a new schedule. So we may well have children also that are caught up having an additional dose of HIB vaccine. So these children are the ones that have had their meningitis at 12 months of age, and they are now going to be coming in at 18 months of age for their 18-month-old vaccines. Once again, you would offer them the HIB dose. However, if the parents don't want it, their payments are not going to be affected. It's very safe for the child to have that additional dose of HIB, but it is a conversation that you would be having with your parents. So just a couple of questions here in the box. If an adult in category A or B is or isn't funded. Okay, so if it's a Pneumovax 23 and the person is under 65 years of age, then it is PBS listed. If it's a Prevnar 13 that you're talking about as a category A patient, then it is completely unfunded. Your 23 valents are NIP funded for Aboriginal people and also for those over 65 years of age. Kathy's asking, when is Men-B going to fit? Where is Men-B going to fit into the SA schedule? That is the absolute biggest question on everybody's lips here in South Australia at the moment, and that has yet to be determined by SA Health, and we are just all having to sit back and wait until we hear that information. We have children coming into our practice as their main practice for all IMS and they live in Victoria. Can they access the new Men-B program in South Australia? No, they can't. They must be a resident of South Australia, is the information that has come from SA Health. Okay, I think we've covered all of those. So if we have a look at Hib disease, so Haemophilus influenzae type B disease, you can see on the left-hand part of this particular graph where we started vaccine programs. And there was a really big decline of Hib disease in a very short space of time. This has been a tremendously successful vaccine program, and it's one of those vaccine programs that we can absolutely say that, you know, improved sanitation, improved nutrition, improved quality of water has made a difference to this disease, because Hib vaccines came into Australia in the early 1990s, 1992 to be exact, and it became on the funded schedule in 1993. So definitely this vaccine has made a tremendous difference, and we just really don't see a lot of Hib cases anymore. It's tremendously successful. So there shouldn't be any problem in moving that Hib dose across to 18 months. So putting it all together now very quickly as we get down the track. Will there be another webinar before the Men-B schedule commences? Anne-Marie, SA Health are going to be doing some face-to-face sessions around the state. The 2 Adelaide sessions are booked out. However, they will be recording one of the face-to-face sessions, is what my understanding is, and that will then be loaded on the website for people to view at any time. Okay, so if we're looking at the old schedule, so these are those kiddies born before 31st of December 2016 and they've had their vaccines. So they're not funded for an ACWI, or they don't need any additional doses of Prevnar 13 or any Hib doses. They're all done and dusted. If we look at the new schedule now, so these are these kids born on or after the 1st of January 2018, it's at this point that their schedule will actually change. So they will only get a Hexa at 6 months. They get an MMR, ACWI and Prevnar 13 at 12 months. They'll get MMR-V and DTP and a Hib at 18 months of age. If we look at the PCV13 transition, or your Prevnar 13 transition, those kiddies that are born 1st of July 17 to December 31st 17, their schedule changes at this particular point here. So for those children, they've had 3 doses of Prevnar 13, but we're definitely going to be wanting you to give them that 4th dose at 12 months of age. They'll get an ACWY instead of their Meningococcal, and they'll also get a HIB. So once again, it's a funded dose of Prevnar 13, but it's not required for their Centrelink payments. If we look at the HIB transition kits, so these are those older kids that are 12 to 18 months of age now, so their scheduling point is going to start here. They've already had their 12-month vaccines, they've already had their MMR and their Meningococcal. So for those children, they can get that 5th dose of HIB, but they don't really need it. However, it is safe to give, talk to the parents about it. It is not tied into their Centrelink payments, but these children are not funded for 13-valent pneumococcal vaccine or an ACWY. If parents want that ACWY, they would have to pay for it. So if they are over 12 months of age but have not yet had their 12-month vaccines, absolutely change them at this scheduling point and give them an MMR and an ACWY and give them that extra dose of HIB at 18 months of age. So technically this group of kids is not funded for that Prevnar 13 dose at 12 months of age because they're quite overdue. The other schedule change, very, very quickly, we're just about to head over time, I think. Vaccination of pregnant women, absolutely. We've been giving pregnant women flu vaccine and DTPA vaccine for some time. Flu has been on the funded program, but DTPA was funded by states and territory governments. So the shift really has just been that the funding has shifted away from states and territories and is now on the National Immunisation Program as a funded vaccine. So vaccinating pregnant women certainly helps reduce complications for them in the pregnancy. Flu and pregnant women are a terrible combination, and we really must get these vaccines into these pregnant women. But also antibody transfer across the placenta helps protect those really young infants in that early stage of life. Get that passive antibody transfer, which is the best way to protect these babies. We've talked in the past about cocooning strategies. Look, you know, absolutely we would love every person breathing on those babies to be vaccinated against flu and pertussis. But the most effective way of protecting that baby is actually those maternal antibodies. So making sure those mums get their flu vaccines in pregnancy at any time of the pregnancy. And definitely that DTP booster, that whooping cough booster, in the 3rd trimester, so 28 to 32 weeks is the absolute optimal period of time. If you leave it too late, they do run the risk then of delivering their baby a week or 2 early, and therefore those antibodies are going to struggle to get across the placenta in time to protect the baby. So it is really safe to give these vaccines to these pregnant mums, so please talk to them about it. If you've got some resistance from these mums, please either connect them through to us here at the Immunisation Hub or through to your PHNs in other states and territories where they've got some immunisation program support for you. People here in Adelaide, we've got champion nurses on the ground that can certainly speak to parents as well. So, Paula has just asked, is there any talk of Men B schedule commencing in other states? Certainly not at this stage, Paula. Disease incidence at this stage doesn't particularly warrant it. Other states and territories really are battling more with serotypes W and Y rather than meningococcal B. So the funding has gone there, but you know, I think it's something that we need to watch, wait and see what disease incidence actually does down the track, really. So if there's last-minute questions, certainly happy to take them, but otherwise I'd really like to thank you for spending your evening with us. I hope you've sat there in your pyjamas and in front of your heater and with a lovely glass of wine. And I really thank you for listening, and I hope it's been helpful.